Hello, everyone. Thank you for joining us for today's webinar. My name is Mary Corey, Education Specialist for WorldLink Medical, and I will be moderating today's event. I would like to mention a few quick items before we begin. First of all, please make note of the features available to you within your GoToWebinar internet browser. In the lower right-hand corner of your screen, you should see the chat box where you can enter your questions to Dr. Rozier. They will be answered at the end of the presentation as time allows. This webinar conference is brought to you by WorldLink Medical. We provide evidence-based, CME-accredited education in preventive medicine and age management with a focus in bioidentical hormones. If you are needing CME credits or you are interested in bioidentical hormone replacement therapy, check out our courses on the WorldLink Medical website. We have added a new Part 1 course for April 13th through the 15th. Registration details will be posted soon. We have recently added to our membership program, effective this month. The annual membership will now include the monthly webinars, monthly journal club, and access to the online article research library through EBSCOhost. Don't miss out. By registering before January 22nd, you will save 10% on the annual membership fee of $495. Hormones and Beyond, a beautiful resort in Tucson, Arizona, and a 20th year celebration for Neil Rozier and WorldLink Medical. It's an event you won't want to miss. Save the date for October 5th through the 7th. Our speaker today is Dr. Neil Rozier. He is a pioneer and recognized leader in bioidentical hormone replacement field, treating more than 3,000 patients almost since its inception in the early 1990s. With over 17 years experience as an educator and practicing physician and 29 years of emergency medicine experience, he has dedicated his life's work to uncovering the medical literature that supports safe and effective protocols for personalized patient care. He lectures worldwide on the benefits of HRT. He is the author of Natural Hormone Replacement for Men and Women, How to Achieve Healthy Aging. It's my privilege to welcome Dr. Neil Rozier for today's webinar from his hometown in Palm Springs, California. Hello, Neil.
Hi, Mary. Good morning, everyone. I'm sitting here looking outside at the mountains. We've got our first rain and snow of the season. The mountains are beautiful, covered with snow. It's presently about 72 degrees in Palm Springs, supposed to be a high of 76 today. I say that for all you people back on the West Coast, East Coast. The impetus for this lecture today comes in the heels of so many of our peers that don't understand why we do what we do. I spend 3 hours in part 1, several hours in part 2, and hours in part 3 and part 4 explaining why we optimize thyroid, the health benefits, feel-good benefits, controversies, et cetera, and I try to review all that literature. The literature that I don't review is the literature that is so critical of why we do what we do. It's mostly from our peers that have been educated just like me, as well as the Endocrine Society and endocrinologists that, with all due respect, don't quite understand the difference between thyroid replacement and hyperthyroidism. At one of the recent courses, Dr. Keith Nichols pulled up an article that was recently published that showed that prescribing thyroid to patients even in high doses, did not cause any adverse effects, atrial fibrillation, death, etc. And yet we're still bombarded on a daily basis by our peers that criticize us for suppressing TSH, because we know that suppressed TSH is bad. You and I were taught that. It's written in the Bible, don't suppress TSH. It causes hyperthyroidism and cardiac death, increased morbidity, mortality, and osteoporosis. So don't suppress the TSH because we know how bad it is. Today's lecture will refute all of that. So my point today is to explain to you and describe to you that optimizing thyroid is not harmful, endocrinologists and our peers, and before you learn how to do thyroid, probably felt the same way, that you should never suppress TSH, and if you do, it causes, quote, hyperthyroidism, which it does not, and we'll get into the terminology later. But my point is to try to explain to you and prove to you that what we do is safe, efficacious, and evidence-based. And in addition, explaining to you and proving to you why your peers do not understand why we do what we do. I can't fix your peers. I will tell you cautiously to use thyroid if the patient has another doctor. If the patient does not have another doctor, that's not an issue. But the problem always comes when your patient goes to their doctor and says, I feel great and I'm on this thyroid, and then the physicians and your peers just have a fit. I cannot fix that. I cannot fix them. I encourage you not to prescribe thyroid to anyone that's going to encounter another doctor that does not understand why you do what you do. On the other hand, I want you to understand why we do what we do, and it is evidence-based, and it is not harmful, and it's definitely efficacious to our patients. That was reviewed in parts 1 through part 4. But I want to review the articles that I don't have time to do in parts 1 through 4 that I think are of extreme importance to understand why we do what we do. Having said that, I want to review 2 articles today. They're a little bit redundant, so they will be a little bit repetitive, but they both look at and address some points and facts that are not addressed in each of the articles that I will review. So this one here is a first one, an examination of a myth. The myth is that prescribing thyroid and suppressing TSH with high-dose replacements causes heart disease, cardiac morbidity and mortality, and osteoporosis. So this is the summary that I'll go through first, and then I will go through the whole entire article and looking at individual articles and studies that support why we do what we do. So high-dose thyroid replacement is included in major treatment guidelines for treatment of bipolar disorders and depression by the psychiatric societies. Psychiatrists are the pros at utilizing high-dose thyroid to treat depression and bipolar disorders. No other specialty tends to have as much experience and wherewithal in helping to make people feel better. Yet it's seldom used, partly because this perception by the Endocrine Society and by the world that there's a cardiovascular risk when we prescribe thyroid. For those of you taking parts 1 through 4, you will understand and realize that we use thyroid to protect against cardiovascular disease because it has such a profound effect on visceral fat, lipids, lipoproteins, and all the cardiovascular risk markers. The cardiovascular risk of high-dose therapy are examined in this study. And the results show that while hyperthyroidism is a significant cardiovascular risk factor causing 20% of premature death rate, remember we haven't got to the definition of hyperthyroidism yet, high-dose therapy treatment does not appear to be a significant cardiovascular risk. So this is the introduction as to there's hyperthyroidism and there's high-dose replacement. They are not the same, but they're commonly lumped together as being the same. And that's a concept that we have to understand. And we will eventually look at why that distinction came to be. High-dose thyroid replacement differs from hyperthyroidism, which is Graves' disease, in significant ways. The sequelae of hyperthyroidism or Graves' disease are increasingly tied to autoimmune complications, which are absent with high-dose replacement. High-dose replacement does not cause an autoimmune disorder. Graves' disease is an autoimmune disorder that's termed hyperthyroidism. Unfortunately, high-dose replacement is commonly confused with hyperthyroidism. It is not the same. The world thinks that it's the same. Do not argue this point with any endocrinologist or internal medicine specialist because they were born and raised just like I was to believe that hyperthyroidism is the same as high-dose replacement. Equating hyperthyroidism with high-dose replacement is incorrect. But everyone knows and thinks that. I don't even go there. I don't even try to explain it to endocrinologists or internists or other peers because they will not understand it because they're going to have to sit through a 2-hour lecture like today's in order to understand the difference. 5 case reports of high-dose replacement treatment associated with AFib in the literature was potentially caused by other factors. We gave it, we saw it, we assumed that it was the same, but when you look at the studies and you dissect each one of those studies, those people that had those risk factors from taking high-dose therapy actually had episodes of atrial fib before they were actually treated with thyroid. Even in overt hyperthyroidism or Graves' disease, the risk of another arrhythmia is minimal, but it is there. There is a risk. But what happens is we extrapolate that slight risk seen with Graves' disease to be included whenever we give thyroid. And that's why everyone fears suppressing the TSH. Oh, you're going to cause atrial fibrillation. I've been taught that. I hear that on a daily basis. You and I were taught that 30 years ago, and you can't get it out of people's brains. However, when compared to many psychiatric medications, high-dose thyroid replacement is safer than most of the psychiatric medicines we use. Well, still, that doesn't mean that there's not going to be any harm of it. Just because it's safer doesn't mean that there's still not going to be some harm. So let's look at what the harm is. Conclusion that we'll look at: the cardiovascular risk of high-dose replacement appear to be low. High-dose therapy is at least as safe, or not safer than many of the psychiatric medicines, which we use with impunity. Well, yeah, there's a risk of the psych meds, but don't worry about it. The risk is so small. It's the benefits certainly outweigh the risk. But with thyroid replacement, oh no, there's a risk, and we can't take those risks, and therefore nobody gets thyroid. High-dose replacement is effective and well tolerated in all the studies. Now, looking at those studies, there's 2 major myths that prevent wide acceptance of high-dose thyroid replacement for the treatment of affective disorders. The first myth is that thyroid replacement, particularly high dose, is a risk factor for developing osteoporosis. We'll look at that next webinar more in much greater detail and look at the specific studies. And the second myth is that high-dose replacement increases cardiovascular risk, both atrial fibrillation as well as cardiac death. First, this review will demonstrate that high circulating thyroid hormone levels resulting from high-dose replacement, that's exogenous replacement, is fundamentally different than hyperthyroidism and Graves' disease, but we extrapolate them to be the same and identical. Clinically, the most significant roadblock preventing the acceptance of high-dose therapy is the disapproval from other specialties, chiefly endocrinologists. This is largely because the endocrinologists and endocrine publications equate high-dose therapy with hyperthyroidism. To them, it's one and the same. Endocrinologists' disapproval of high-dose replacement as an effective illness treatment is puzzling, considering the recognition and support for the use of high-dose therapy to prevent the recurrence of well-differentiated thyroid cancer. Well, it's okay to do it in people that have thyroid cancer, but it's not okay to do it in anyone else. Well, aren't you afraid of causing the harm in those patients with differentiated thyroid cancer? No. Do any studies show harm in differentiated thyroid cancer replacement? No. Well, then why is it that it's okay to do it with them, but not in any other circumstance? That's the issue. That's what they don't understand. The use of thyroid augmentation for major depression is well researched and has been found to have significant benefits. Extensive research, we'll look at the articles later, has shown that high-dose replacement is significantly helpful in preventing recurrences of stage 2, 3, and 4 differentiated thyroid cancer. That's how you prevent it. Yeah, but aren't we causing harm? No, no study shows harm. Well, then why can't we use it for other circumstances? That's the problem. Well, it's okay to do it here, but it's not okay to do it there. Why is it okay to do it here? Because there's no study that shows any harm. Well, why can't we do it over there? Well, because other studies show harm. No, we're extrapolating the harm of Graves' disease to high-dose replacement, and we should not. However, even though high-dose replacement is included in the major treatment guidelines, most psychiatrists do not prescribe it, possibly because high-dose replacement is universally condemned by all thyroid associations and AACE. The main difference between high-dose replacement and hyperthyroidism is that the high circulating levels of thyroid hormones in subjects with Graves' disease or Graves' hyperthyroidism are caused by an autoimmune antibody that mimics TSH. So TSH stimulates the thyroid gland. The autoantibody also stimulates the gland to produce excessive amounts of thyroid hormone. This is frequently accompanied by multiple autoimmune conditions also. It's not only the effect on the thyroid gland, but it affects multitudes of other tissues, and this antibody attacks all these other tissues, causing the pathology and the physiology behind hyperthyroidism. There's mounting evidence that many or even all of the sequelae previously attributed to high circulating levels of thyroid hormone in Graves' disease are in fact due to an autoimmune antibody. So it's really not the thyroid hormone, it's the autoimmune antibody. Because in every circumstance, when you remove the thyroid gland, the autoantibodies persist, and the autoantibodies still cause disease in these other tissues. When you remove the gland and then replace with thyroid, the disease progresses. You don't have high levels of thyroid when you physiologically replace it in patients that have had Graves' disease treated with either surgery or I-131. Yet the disease progresses. It's not due to the thyroid hormone because we've corrected the thyroid hormone. Then why does the disease progress? It's the autoimmune disease that progresses. You fix the high levels of thyroid. You've brought the levels of thyroid back down to normal by physiologic replacement. Yet the disease continues to progress. Why? It's not due to the thyroid hormone, and it's not due to the thyroid gland. It's the autoimmune disorder that progresses. In fact, cardiovascular disease, pulmonary arterial hypertension, and myxomatous cardiac valve disease also continue to progress, in spite of the fact that we've removed the thyroid gland and we've taken away the source of that high level of thyroid. Yet the disease progresses. It's not the thyroid hormone that's causing the problem. Conversely, there's no suspicion that high-dose replacement is associated with autoimmune problems. We don't see that in any study. In this one study, in the first study, both groups were started at a dose of 100 micrograms of T4, and that was titrated up to 500 micrograms per day or 0.5 milligrams. That's a big dose. There's now evidence that blood thyroid levels of subjects do not accurately reflect the more important intracellular thyroid levels. So in spite of the fact, and we see this with the prostate and other tissues too, you have very high serum levels but very low intracellular levels. This could potentially be the biggest difference between high-dose replacement and hyperthyroidism, where maybe the high-dose replacement is extracellular in the serum that you measure, but hyperthyroidism, Graves' disease, is inside the cell. It's the autoantibodies that are inside the cell that are causing the pathology. This discrepancy between pituitary cells and the rest of the body can lead to false normal thyroid blood levels when the rest of the body is actually in a state of cellular hypothyroidism. We see this all the time. I term that type 3 hypothyroidism, where the serum levels of T4, TSH, and T3 are perfectly normal, but yet the patient is clinically hypothyroid, even though the levels are perfectly normal, but inside the cell, they're not. That's why the patients have persistence of symptoms in spite of the fact that their levels are perfectly normal. Discussion on this article. There have been two major objections to the use of high-dose thyroid replacement to treat affective disorders. One, it causes the clinical sequelae of hyperthyroidism or Graves' disease, and number two, it causes osteoporosis. However, careful examination of the literature reveals that these objections turn out to be myths. The first myth, that high-dose replacement poses a risk for osteoporosis, was disproven in an earlier review. I'll go over that paper next webinar. What differentiates high-dose replacement from hyperthyroidism? Well, the hyperthyroidism or Graves' disease causes 20% more premature death in affected subjects than in the population at large. Even though when you correct the disease, you remove the thyroid gland, the thyroid autoantibodies persist and they attack other tissue, which is why you still see an increase in cardiac death and other death that's 20% higher than the general population. Yet neither the literature describing the use of high-dose replacement for affective disorder or for differentiated thyroid cancer, nor clinical experience show any indication of this wholesale increase in the rate of death that's seen with Graves' disease, despite the fact that high-dose replacement therapy continues for decades. We don't see it in any study, but yet we extrapolate and assume, and unfortunately, as we see in so many other issues with hormone replacement, people extrapolate and assume, and they extrapolate and assume incorrectly. Because when the studies show there is no harm, don't extrapolate and assume. When the risk of high-dose therapy were directly studied in the 3 papers discussed above, indicate that high-dose therapy used to prevent thyroid cancer recurrence does not increase cardiovascular risk or increase premature death in any study with high-dose replacement to treat DTC, nor do we see any increased risk in any study where we use high-dose therapy for treatment of psychiatric problems. But everyone extrapolates. The question arises of why is there such a discordance between the risk of hyperthyroidism, Graves' disease, and high-dose therapy? It was previously posited that the causes of morbidity and mortality associated with Graves' disease were due to high circulating levels of thyroid hormone. And therefore, if that is the case, then using high-dose thyroid was going to cause the same disease and same morbidity and mortality. Well, it doesn't. On the other hand, the lack of signs and symptoms of thyroid toxicity in patients with affective disorders who receive high-dose replacement would seem to contradict this. You can use high-dose replacement in the patients that have psychiatric problems and they don't have symptoms of thyroid toxicity. Yet in patients with Graves' disease, they have symptoms of thyroid toxicity. In patients with DTC, we use high-dose therapy. They don't have symptoms of thyroid toxicity. But they have a suppressed TSH. I know we'll get to that. Having a suppressed TSH is not a symptom of thyroid toxicity. Palpitations, tachycardia, jitteriness, weight loss, etc. are symptoms of thyroid toxicity that we don't see with high-dose replacement. The biggest difference between high-dose replacement treatments and Graves' disease hyperthyroidism is that Graves' disease is mediated by an autoimmune process. A growing body of evidence indicates that the risk of medical complications of hyperthyroidism, Graves' disease, are caused by the accompanying autoimmunity. It's the disease process in the other tissues. It's not the thyroid hormone that's causing the disease. It's not the thyroid hormone that's causing the increased cardiac death and other complications of Graves' disease. It's the autoimmune disorder that's causing the problem. When you get rid of the thyroid gland, the autoimmune problems still persist. We'll see what happens when you treat with I-31 later. The myth that high-dose replacement carries the same risk as Graves' hyperthyroidism stems from the correlation between Graves' hyperthyroidism and high circulating thyroid hormone levels. And we've assumed and extrapolated, and we shouldn't. You got to study it. They didn't study it, they just observed it. So this correlation with hyperthyroidism being assigned the status of cause and effect is incorrect and inappropriate. Easy to do, and we do that with so many other things. Clearly, the lack of cardiovascular osteoporosis risk when high-dose replacement is used to prevent recurrence of thyroid cancer shows that this is not a cause and effect relationship. That's why it's done. Oh, there's no harm in giving DTC patients high-dose thyroid because those people are somehow immune to the adverse effects of high-dose thyroid, whereas the standard population is not immune. This inaccuracy has been promulgated by the chronic misuse of the terminology, calling all suppressed TSH levels or elevation of thyroid hormones hyperthyroidism in the literature. And that's the problem. To this day, all endocrinologists and all the literature says a suppressed TSH is hyperthyroidism. It's not. It may be biochemical hyperthyroidism, but it's not true thyroid toxicity. There is at best confusion about the difference between high-dose replacement and hyperthyroidism Graves' disease. At worst, there's remarkably resolute conviction that there's no difference. To some, the use of high-dose thyroid replacement is not equivalent to Graves' hyperthyroidism in any study. The definition of thyroid toxicity is high circulating thyroid hormone levels with clinical signs and symptoms of excess thyroid hormone, confirmed by elevated thyroid laboratory values, high T4, high T3, suppressed TSH, and signs and symptoms of excess. We don't see signs and symptoms of excess with high-dose replacement. It is only high levels, but we extrapolate those high levels to be Graves' disease and the associated harm of Graves' disease. Clinically, high-dose replacement suppresses TSH levels and often results in elevation of T4 and T3. However, there's no actual thyroid toxic signs or symptoms. This would not be considered evidence of thyroid toxicity. It's biochemical evidence that there's excess in the serum, but not of thyroid toxicity or any of the harm associated with Graves. The medical literature reveals a nearly complete lack of differentiation between high-dose replacement and hyperthyroidism. They're assumed to be the same. They are used interchangeably. And when they look at the studies of patients with Graves' disease and high-dose replacement, they extrapolate them to be the same. And they shouldn't. The failure to keep in mind that high circulating thyroid hormone levels and the associated sequelae of Graves' hyperthyroidism are a correlation in disregard of appropriate terminology help create this and maintain the myth that high-dose replacement carries the same risk as hyperthyroidism. It doesn't in any study, but they extrapolate it to be the same. The problem here is that when they look at levels in the population, and that's what Dr. Nichols looked at recently, was a study where high levels of thyroid hormone are associated with increased cardiac death and morbidity and mortality. There's probably a dozen studies out there right now showing that high levels of thyroid hormone are associated with increased morbidity and mortality. Association does not prove causation. Yes, but high levels are associated. These are not high levels from giving people thyroid. These are high baseline levels. Well, guess what? Who has high baseline levels? Normal people? No. The people that have high baseline levels are patients with Graves' disease. Those are the people that have high levels, and those are the people with increased morbidity and mortality due to the Graves' disease autoimmunity. But we extrapolate that high levels of thyroid to be associated with harm to mean that those people are actually being treated with thyroid. No, none of those people were being treated with thyroid. Those are baseline levels of a population, and probably 5 to 10% of the population has some form or element of Graves' disease or hyperthyroidism. Those are the people that are at risk, but don't extrapolate baseline levels of being high to the same thing of what happens when you give thyroid. Case in point, estrogen in women. In every study, there's hundreds, high levels of estrogen, high levels of estradiol, baseline levels, are associated with increased risk of breast cancer, cardiac disease, and death. It's not disputable. All studies show high levels are associated, but those high levels come from visceral fat in menopausal women, and it's the visceral fat and the dyslipidemia and the inflammatory condition that's causing the death. How do you know that? Because in every study when we give estrogen in the form of estradiol, notwithstanding the WHI trial, in every study when we give estradiol is protective against heart disease. Yes, but high baseline levels are associated. Same thing applies with breast cancer. High baseline levels of estradiol are associated with an increased risk of breast cancer. High levels of estrone that are produced by visceral fat are associated with increased risk of breast cancer in every study. Yet, in every study when we give estradiol to women, and even Premarin, there's a decreased risk of breast cancer. So what happens when you give it, and when you observe what happens when you give it, is completely different than what you observe at baseline. You can't take a baseline observation and extrapolate that to, this is what happens when we give it. Same thing with testosterone in men. High baseline levels of estradiol are associated with harm in every study. Increased risk of diabetes and cardiac disease in men. Every study, high levels baseline are associated with harm. And what we've done is we've extrapolated that to, well, when we give testosterone or estradiol, it's the same issue. It's the same problem. It's harm. Show me the study. Don't quote the flawed Finkel and vegan studies. What study in the last 50 years, there's hundreds of them to pick from, meta-analysis, randomized controlled trials. What studies show that giving testosterone increased the risk of heart disease? None. What studies showed benefit and protection? Almost all of them. So high levels are associated. You can't extrapolate that to what happens when you give it. You have to do an interventional study and see what happens when we give it. It's an interesting thought. It's an interesting theory, but you can't extrapolate. And that's what everyone's done with thyroid. High levels of thyroid hormone baseline are associated with harm. Yes, but that's not the same as when we give it. You need to give it and show harm. So far, we haven't seen any study when we give extremely high doses. And probably what's confusing here is that the dose used in these studies is extremely high. I don't use these extremely high doses. I optimize. My TSH is suppressed. But the T4 and T3 is pretty much at the upper end of the range of optimal to that of a young adult. It's not Graves' disease hyperthyroidism, for example. Graves' disease hyperthyroidism, you'll get a free T3 of 40, 50 to 60. In the patients that I treat with thyroid, I get a free T3 of 4, 5, 6, or 7. A free T3 level of 6 or 7 is not Graves' disease hyperthyroidism. That's the level that we had in our youth. The 18, 19, and 20-year-olds will have a free T3 of 7, not a free T3 of 50, which is what you get with Graves' disease. But everyone extrapolates, well, you suppress TSH with optimizing your thyroid. It's the same disease and the same harm as suppressing the TSH when you have Graves' disease. It's not, but everyone says and thinks that it is. I'm not trying to convince the endocrine world of that. You can't. It's impossible. I don't try to convince my peers. I don't explain it to them. It would take me hours and hours and hours to take them through this process of trying to explain that what we were taught and misled to believe is not true, which is unfortunate. There's clear experimental evidence that high-dose replacement and hyperthyroidism should not be equated. They are not the same, but the rest of the world does it. You can't fight it. They do it. I want you to understand it's not the same. I don't want you to try to explain it to someone else. They will not understand. You are wasting your time. It's really a shame. The failure to keep in mind that high circulating thyroid hormone levels, Graves' disease, and the associated sequelae of hyperthyroidism, Graves' disease, are a correlation. It's an observation. An observation does not prove causation. It's simply a correlation. We see it, we observed it. And the disregard of appropriate terminology, hyperthyroidism versus high-dose replacement, help create and maintain the myth that high-dose replacement carries the same risk as hyperthyroidism. It does not in any study. Oh, it does in some studies, I should say. Yeah, but in those studies, the majority of the population studied were actually patients that had Graves' disease. So their patient groups were contaminated with patients with Graves' disease. Baseline levels were high. Yeah, those are patients with Graves' disease. It's not normal people. Normal people don't have high levels. Well, you have to assume it's the same. No, you cannot assume. And that's the harm when you assume. This is the second of 2 review papers debunking the myth that high-dose replacement carries the same risk as hyperthyroidism, Graves' disease. Clearly, this is not true. While the previous review dealt with the myth that high-dose replacement is a factor for osteoporosis, we'll look at that next time. It's not true. And in part 2, I reviewed that. I went over 50 studies showing that high-dose replacement does not cause osteoporosis. The present findings demonstrate that high-dose replacement therapy does not carry the same cardiovascular risk as hyperthyroidism. Moreover, the published evidence supports that high-dose replacement is at least as safe or safer than other psychiatric medicines that we use with impunity. And we said, well, you know, yeah, there's a slight risk. It's 1 out of a million, but the benefit is so much greater. But we ignore that for thyroid replacement. Furthermore, high-dose replacement treatment for affective disorders is well tolerated in every study. This is the second study, somewhat repetitive, but there's some new information too. I didn't sort out the difference. Elevated levels of circulating thyroid hormone, that's baseline, that's Graves' disease, do not cause the medical sequelae of hyperthyroidism. Clinicians have been reluctant to use high-dose thyroid replacement to treat affective disorders because high circulating levels of thyroid hormone have traditionally been equated with hyperthyroidism, Graves' disease, and understood as the cause of the medical sequelae of hyperthyroidism. It's that high level of thyroid that's causing the disease. No, it's not. Yes, but the study showed harm. That's baseline. That's an observation. In order to prove your observation true, you then have to give it, study it, and see what happens when you give it. What happens when we give it? No, you don't see that. In fact, you have a decrease in cardiovascular disease when you optimize thyroid, even though the TSH is suppressed. The conclusion is not supported by high-dose thyroid therapy research. Let's look at those studies. This is a summary. There exists a large body of research involving the use of high-dose thyroid replacement to prevent the recurrence of differentiated thyroid cancer and to treat affective thyroid disorders. Affective psychiatric disorders. A review of this literature finds a lack of support for high-dose therapy as a cause of osteoporosis, nor is there support for an increase in morbidity, mortality, cardiovascular-wise, associated with high-dose replacement. It's Graves' disease. This finding contrasts with the well-established morbidity and mortality associated with Graves' disease. We know that. And thyroiditis and other endogenous forms of hyperthyroidism. The endogenous form is not the same as the exogenous TSH suppression, I didn't call it hyperthyroidism, that we see when we treat with thyroid hormone. The lack of evidence that exogenous high-dose replacement causes osteoporosis, cardiac abnormalities, or increases morbidity and mortality, compared to the significant morbidity and mortality associated with Graves' hyperthyroidism, requires an alternative cause for the medical sequelae of hyperthyroidism. That is an autoimmune mechanism. Study after study after study shows the same thing, but we unfortunately extrapolate them to be the same. Conclusion, high circulating levels of thyroid hormone, meaning when we give it, is not the cause of the sequelae of hyperthyroidism. The reluctance to use high-dose thyroid is unwarranted because, unfortunately, even the experts, you would think that would know this, don't. They completely miss. And that's why, I couldn't figure out when I was going through my training that they kept saying observation does not prove causation. And I got so tired of hearing that, and it's like it didn't mean anything. But unfortunately, everyone tends to ignore that. And it's such an important point now that I didn't understand way back then. The assumption that high-dose thyroid replacement causes iatrogenic hyperthyroidism affects the adoption of T3 or T4 to treat affective disorders. And therefore, we avoid it because we don't want to cause Graves' disease. Although high levels of circulating thyroid hormone have been accepted as the cause of most medical sequelae associated with Graves' disease, recent review papers have not supported this assumption, suggesting that high-dose thyroid replacement is unlikely to lead to the same sequelae and harm as Graves' hyperthyroidism. But everyone knows that it does, but it doesn't. This calls into question the belief that the morbidity and mortality of hyperthyroidism Graves' disease are caused directly by the high circulating levels of thyroid hormone, and raises the possibility that high-dose replacement treatment is substantially safer than conventionally believed. They're not the same. High-dose therapy is routinely used to prevent the recurrence of thyroid cancer and to treat affective disorders. Any harm? No. Yes, but there's some studies that did show harm. Yes, and those studies were contaminated by patients that had Graves' disease. They didn't make a distinction because they were observational studies. You have to do a study where you weed out anyone with Graves' disease and then give thyroid and see what happens. They've done that. It is critically important to distinguish hyperthyroidism, Graves' disease, from high circulating levels of thyroid hormone given exogenously caused by thyroid medication. But yet, they ignore it. The studies are there. They don't understand it. Although the two are often confused, the latter does not meet the formal definition of hyperthyroidism discussed below. High-dose replacement does not cause thyroid toxicity. Well, it suppresses TSH. That's not thyroid toxicity. Surprisingly, some examples of this confusion are found in authoritative endocrine guidelines. You would think that they'd get it right. They don't. Well, how can all these guidelines and all these experts in the AACE and the American Thyroid Association be wrong? How can that possibly be? That's what's confusing. In the British Thyroid Association Guidelines for the Management of Thyroid Cancer, the guidelines cite 3 studies as evidence of the cardiovascular risk of high-dose replacement. However, all 3 studies evaluated patients with Graves' disease and subclinical hyperthyroidism. They didn't weed out all those people with Graves' disease. What they should have done was weed out all the patients with Graves' disease, then give them thyroid. And guess what? In those studies that have done that, we haven't seen any increased problem. Similarly, the revised American Thyroid Association management guidelines for patients with thyroid nodules. Yes, we treat thyroid nodules with high-dose replacement. Yeah, but isn't that harmful to suppress the TSH? No. Somehow having a thyroid nodule, enjoy my sarcasm, somehow having a thyroid nodule protects you against the harmful effects of high-dose replacement. And differentiated thyroid cancer somehow protects you against that harm of giving high-dose thyroid. It states that the adverse effects of TSH suppression may include the known consequences of subclinical thyroid toxicosis, including exacerbation of angina in patients with ischemic heart disease and the increased risk for atrial fibrillation in older patients. A single study is cited to support this conclusion. And again, that study was contaminated with patients with Graves' disease. But no other study supports that. One study that was contaminated. Well, what about all the other hundreds of studies where we've given high-dose replacement to patients with ductal differentiated thyroid cancer? None. Like some of the studies discussed in this article, this study made the crucial error of conflating the disease of Graves' hyperthyroidism with high-dose thyroid replacement. They all do. The authors studied a mixed group of patients with hyperthyroidism and those receiving thyroid hormone replacement therapy. So this whole study is contaminated with half the patients are getting high-dose replacement and half the patients have suppressed TSH from hyperthyroidism from Graves' disease. You can't include them to be the same, but they did. And they extrapolate harm then, but the harm is from the Graves' disease. Consequently, no conclusions can be drawn regarding the risk of clinical administration of thyroid hormone, separate from the disease of hyperthyroidism. This guideline also asserts a risk of osteoporosis with high-dose replacement. However, the study that was cited concludes that subclinical hyperthyroidism is a risk factor, but the evidence for the use of exogenous thyroid is inconclusive. It's because all the studies where they eliminated Graves' disease and gave exogenous thyroid replacement and suppressed the TSH did not show osteoporosis. I've reviewed all those studies in part 2. I reviewed more studies in part 3. We'll look at a conclusion summary article next webinar. Once again, the authors failed to distinguish high-dose thyroid treatment from the disease of hyperthyroidism from Graves' disease, invalidating that conclusion that the former causes osteoporosis. But when you eliminate Graves' disease from these studies, then giving thyroid does not. Results of the Texas Algorithm Procedural Manual for the Treatment of Bipolar Disorder recommends doses of T3 up to 160 micrograms. 160? 1 grain of armor contains 9. When I did the lecture on chronic fatigue, studies show that doses of 50 to 100 micrograms of T3 worked well to treat fibromyalgia and chronic fatigue without any side effects, problems, complications. In this study here, they used up to 160 micrograms of T3. That's a big dose. Still didn't see any problems. There's a large body of literature on high-dose therapy used to suppress the return of differentiated thyroid cancer. It includes data on changes in bone mineral density. The most recent review was done in 2006 by Hemster et al. The authors evaluated 21 studies of high-dose replacement used to prevent the recurrence of differentiated thyroid cancer. The authors concluded, our data suggests that postmenopausal women with subclinical hyperthyroidism are most at risk, whereas no increased risk was observed in men and premenopausal women. To further tear that apart, there's a couple studies showing that in postmenopausal women that got thyroid, that they lost bone. The problem with those studies was they're all postmenopausal women not on hormones, and there's no control group. So indeed, postmenopausal women do lose bone. When you gave them thyroid, did they lose any more bone on thyroid than postmenopausal women not? They didn't study it. They didn't have control groups. Another flaw, but yet when you look at the study and look at the results of it, you say, oh, okay, see here it shows that menopausal women on thyroid will lose bone. Yes, they do lose bone, but the problem with losing bone was not related to thyroid hormone. It was related to the fact that they were postmenopausal. The increased risk in postmenopausal women is widely accepted. However, the data supporting this conclusion is questionable. Among the cross-sectional designs, only 4 found a decrease in bone mineral density. 10 did not. All received high-dose replacement for the treatment of thyroid cancer. However, in those studies where they lost bone, women that were given calcium did not lose bone. So really, is it the estrogen or is it the thyroid? The conclusion that high-dose therapy caused a decrease in bone mineral density is not supported. This indicates that only women with inadequate calcium intake are at risk, not those that are on thyroid, and those with loss of estrogen. The second longitudinal study, reviewed by Hemster et al., reported an increased risk for postmenopausal women as minimal. Although statistically significant, reduction in bone density was seen. However, the authors of the original study concluded that the error was in the DEXA measurements, and it made it unlikely that these minimal differences were really meaningful. Again, another flaw in the study. 3 more studies have assessed the risk for bone mineral density when high dose was used to suppress the return of thyroid cancer. Notably, there was no difference in any of the subgroups, including postmenopausal women. The most recent study in Japan enrolled 225 women, a randomized controlled trial that evaluated the effects of high-dose therapy. The group that received high-dose therapy had a mean TSH of 0.07. Control group at TSH 3.1, which is perfectly in the middle. Overall, the study found no significant differences in bone mineral density between the control group and the treatment group at any time period. Multiple studies show the same thing. The final remaining study is the most important from the point of view of differentiating hyperthyroidism from high-dose replacement. There's 4 groups that were studied, and they were all postmenopausal women. The first group had toxic multinodular goiter. The second group had Graves' disease or Graves' hyperthyroidism. The third group didn't have Graves, didn't have toxic multinodular goiter, but they were given high-dose replacement for thyroid cancer. The mean TSH values for the 4 groups were 0.1 for the goiter, 0.084 for Graves' disease, pretty suppressed TSH, 0.06, almost the same for high-dose replacement therapy, and 1.8 for healthy controls that were not on thyroid. Biochemical markers of bone turnover were significantly higher in the first 2 groups with toxic goiter and Graves' disease. However, there is no significant bone turnover in the patient group that had received thyroid hormone. Only the first 2 groups had significantly lower bone mineral density. Those treated with high-dose replacement and healthy controls had no loss of bone mineral density. There's no difference in bone mineral density between the control group and the patients treated with high-dose replacement. The only difference was in those that had Graves' disease. Now you see why it's important to differentiate between the 2 groups, and this study was excellent in that it did that. This head-to-head comparison provides important evidence that there's fundamental differences between hyperthyroidism of Graves' disease, it's an autoimmune disorder, and high-dose replacement on bone mineral density, even in a sample consisting entirely of postmenopausal women. If the study did not allow for this separation, then the study is flawed. 4 psychiatry studies have addressed the effects of high-dose replacement on bone mineral density. None of these studies showed a clinical significant decline in bone mineral density, and they weeded out those with Graves' disease so that the study was not contaminated with patients with Graves' hyperthyroidism. Let's review the cardiovascular morbidity risk of high-dose replacement. 3 studies found no increased risk of premature death in patients treated with high-dose replacement. A multi-site study done in the U.S. evaluated the effects of thyroidectomy, administration of radioactive iodine, and high-dose replacement on the survival of patients with thyroid cancer. High-dose replacement increased survival for patients with stage 2, 3, and 4 thyroid cancer. Increased survival? I thought it would be a decreased survival. No, it increases it. You mean beyond baseline? Yes. The overall mortality rate of the high-dose thyroid group was 1.9%, and the death rate of patients treated only with replacement doses was 3%. Interesting. Which group would you like to be in? The one that lives longer? That's the high-dose replacement. Yeah, but I thought that causes death. No. Don't extrapolate Graves' disease to high-dose replacement. Sugatani and Fujimoto study also evaluated cardiovascular mortality. There was 1 death in the high-dose replacement group, 4 deaths, 3.8%, in the control group. No, there's no increased risk. A study done in the Netherlands followed 504 patients in complete remission from thyroid cancer who were being treated with high-dose replacement therapy. And that survival in that group with thyroid cancer on high-dose therapy was compared to the baseline mortality in the general population. There's no significant difference in the number of cardiovascular-related deaths or all-cause death in individuals treated with high-dose replacement to prevent their thyroid cancer from returning. The authors concluded that disease-free patients after thyroid carcinoma have a normal residual lifespan, as opposed to patients with Graves' disease, and that high-dose thyroid and other treatments for differentiated thyroid cancer do not shorten life expectancy. Yet everyone thinks it does because high levels are associated with harm. Only one prospective study reported increased cardiovascular death associated with differentiated thyroid cancer. Was it the thyroid hormone? Was it the cancer? Don't know. The authors acknowledged a number of problems with the data. That's the other problem. Even though one study showed an increased risk, the data sources for the cause of death among the study sample included public health records, hospital records, outpatient records, autopsy reports, and information from general practitioners. The general practitioner said cause of death, Graves' disease. Cause of death, thyroid cancer. Well, they were getting thyroid hormone. Well, maybe it was the thyroid hormone that caused the death. Now you see how it's all extrapolated to be the same. Comparison data for the general public came from a single source. The author stated that the cause of death was reported by the Statistics Netherlands or the patient's record and general practitioner, and it may not be fully in accordance with each other. So we really don't know why they died. It's just a report that was written, and we don't really know. Yet, that's what they used in the study. This discrepancy makes calculation of hazard ratios problematic, of course, because hazard ratios are generally considered valid only when the data from the treatment group and the control group are similar. Yet, in this case, it was definitely not. But some people may want to hang their hat on that one study. But all the other studies show no harm. Only a single paper could be found that purported to show increased atrial fibrillation with high-dose replacement. Only one? Yeah, all the other ones do not. The prevalence of atrial fib in this population was then compared against the prevalence of atrial fib in the age-adjusted general population. 2 patients were found to have long-standing atrial fibrillation, and 12 patients developed paroxysmal atrial fibrillation. These results must be interpreted with caution because the authors use different definitions of atrial fib in the thyroid cancer population that was what's used in the general population. One can be, well, they have paroxysmal, or the other ones, no, they have constant. The general population data was obtained from a 2001 study in which only non-transient atrial fibrillation was counted. Whereas in the other study, it was different. In order for the comparison to be valid, this author should have excluded from the calculation the 12 patients with paroxysmal atrial fibrillation, but they didn't. The study is therefore contaminated or flawed. Proper classification leaves only 2 patients with atrial fib and indicates that the risk of atrial fib is not increased by high-dose replacement. Yeah, but the study showed people will look just at the conclusions, but as I explained to everyone, read the damn study. What did the study show? Was there biases in it? Yeah, sure. Was there a problem? Yeah. Yeah, but when you read the conclusion, it's different than what you will take away when you actually read the study. It should be noted that over the mean duration of 11 years, no deaths were reported among patients exposed to high-dose replacement. No other papers, studies, research can be located showing an increase in arrhythmias, atrial fibrillation, or otherwise with high-dose replacement. Yet everyone knows and thinks because that's what we were taught originally. Our confirmational bias is strong. We all know from the day we were born that when you suppress the TSH and cause hyperthyroidism, that you're going to get atrial fib. but there's no study to show that when you give it, that it causes it, except for this one, which was flawed. And when you take away the flaw, then there was no increased risk. But everyone knows and thinks that there is. But no one can show any study other than someone says. In contrast to high-dose replacement, hyperthyroidism, Graves' disease, is associated with a plethora of cardiovascular problems that can be lethal. The mortality of patients with hyperthyroidism from Graves is 20% higher than that of the general population. And what we've done is we've extrapolated, well, when you suppress the TSH and give thyroid, you're increasing that risk also. But it's not. Graves' disease is an autoimmune disorder, the most common cause of hyperthyroidism. And the disease is triggered by an autoimmune autoantibody that mimics TSH, both in the thyroid gland as well as in all these other tissues. There's TSH receptors everywhere. They're not exclusively found in the thyroid gland. They're found in heart, bone, muscle, nerve tissue, eye tissue. The effects of Graves' disease are not limited to the thyroid gland. 90% of the patients will have one or more other pathologies, like exophthalmos, due to the antibodies attacking the muscles of the eye. And when they attack the muscle contracts. So when it contracts, it pulls the lid up, which gives you this exophthalmos picture. The orbitopathy is due to the antibody that's attacking the muscle. It's not due to thyroid hormone. The dermopathy, that's when you get this myxedema and myxoid degeneration, cardiac valve prolapse. So there's a multitude of problems that you see in patients with Graves' disease that you don't see in patients that get thyroid replacement. Atrial fib is the most common cardiovascular sequelae of hyperthyroidism, Graves' disease, developing in about 10 to 30% of patients, compared to about 1 to 9% of the general population. There's a nice article published in JAMA about 12, 13 years ago that addressed the issue of should you test thyroid in patients that present with atrial fibrillation. The conclusion of the study was it is so rare and so difficult to find that the recommendation from JAMA was don't test thyroid in patients with new onset atrial fib. Who sees the most patients with atrial fib? I do. In the ER. They don't go to the cardiologist, they go to me. Do I test the thyroid? No. Ultimately, they will get tested. But I go by what JAMA said. No, I don't test the thyroid. Sometimes the consultants will say, how come you didn't test the thyroid? Well, because JAMA said you don't need to. Oh, no. Hyperthyroidism can cause atrial fibrillation. You need to test the thyroid. Then I ask the consultants, have you ever seen one? Well, no. But they still do it anyway. Discussion and summation. Hyperthyroidism carries a multitude of health risk. In contrast, the evidence shows that high circulating levels of thyroid hormone from external sources, i.e. exogenous replacement, carry little or no medical risk. A large body of studies evaluating the risk of high-dose replacement has found a profound discordance between high-dose therapy risk and the risk of Graves' disease hyperthyroidism. At this time, the evidence leads to the conclusion that the major medical sequelae associated with hyperthyroidism from Graves' disease are not caused by high circulating levels of thyroid hormone, but rather the autoimmune disorder. Since the doses of high-dose thyroid replacement that were studied caused suppression of TSH, it can also be concluded that low levels of TSH play little or no role in the medical sequelae associated with hyperthyroidism. That study that Dr. Nichols presented at the last course looked at what happens in these patients that have suppressed TSH that are treated with high-dose thyroid to suppress their TSH. They saw no atrial fibrillation, no cardiac sequelae, and no increased risk of cardiac death. Yeah, but the TSH was suppressed, meaningless. It played no role at all. But yet, that's what we were taught and misled to believe since our infancy. Discussion of osteoporosis risk. In one study that directly compared hyperthyroidism with high-dose replacement treatment, the bone turnover markers were elevated for both. However, even in the presence of high bone turnover markers, that's CTX, NTX, The high-dose therapy group did not have any decrease in bone mineral density. The possible deleterious effect on thyroid hormone therapy on bone mineral density has been debated for the last 3 decades. It's really probably menopause and loss of estrogen and hormones, not due to giving thyroid. There's general agreement that treatment with high-dose therapy does not represent a risk for decreasing bone mineral density in men or premenopausal women. It does in menopausal women, but in menopausal women, they all lose bone, and there was no control groups in these studies. This is reflected in the American Thyroid Association guidelines for the treatment of thyroid cancer. It warns of a potential risk of osteoporosis from high-dose replacement, but only in postmenopausal women. But after close inspection of the studies purportedly showing a decrease in bone mineral density in postmenopausal women, the effect of high-dose replacement in postmenopausal women should be reconsidered. It's probably due to the estrogen and not the thyroid. A review of the original studies used by Hemstra to implicate high-dose therapy as a risk for osteoporosis data indicates that none of the long-term studies showed a decrease in bone mineral density in postmenopausal women treated with thyroid. In one of the 2 studies, only women with inadequate calcium intake experienced bone loss. All you need to do is give calcium and vitamins. Based on the above considerations, the most reasonable interpretation of the data appears to be that there's an absence of risk of osteoporosis with high-dose replacement therapy. Yet your peers, all your doctors, even the patients will say, oh, I'm going to lose bone, I'm going to get osteoporosis. Yeah, show me one patient that's had osteoporosis. That's why I measure NTX and CTX levels in anyone that I treat with thyroid hormone. Unfortunately, most of my peers do not know how to interpret those numbers. In part 2, we looked at, no, actually in part 3 with vitamin D, but also in part 2 when we looked at DEXA reports, all my patients have improved bone mineral densities on all the hormones and thyroids that I prescribe. I showed you those DEXA scans. In contrast, studies with Graves' disease have consistently reported a 12 to 20% reduction in bone mineral density in hyperthyroid subjects, and we've extrapolated that to giving thyroid causes bone loss. You shouldn't extrapolate and don't assume. Cardiovascular mortality. Hyperthyroidism and Graves is associated with a number of potentially lethal medical complications. The mortality is 20% higher. This is in contrast to the findings. The 3 studies reported mortality data associated with high-dose replacement found no indication of increased mortality or any cardiovascular risk. They're not the same. Don't extrapolate them to be the same. In the studies with control groups which represent a more valid study design, control meaning the patients with Graves have been weeded out, there's a numeric trend towards fewer deaths among patients that take high-dose thyroid. Here we go. Which group would you like to be in? I want to be in the high-dose replacement. Those are the ones that live the longest. Yes, but my doctor says. I know your doctor doesn't understand because he didn't listen to this lecture. Overall, the absence of increased mortality indicates either no or minimal risk for high-dose replacement. But, sorry, your peers will not know or understand that, which is too bad. There's mounting evidence that the sequelae of Graves' disease, including pulmonary artery hypertension, cardiac valve involvement, and specific cardiomyopathies are linked to the autoimmune process, not due to thyroid hormone. The high circulating levels of thyroid hormone are caused by the TSH receptor autoantibody that mimics TSH. Graves' disease, like most autoimmune disorders, is frequently accompanied by multiple autoimmune problems and increased morbidity and mortality. In Graves' disease, the risk of autoimmune-mediated problems does not end with the suppression or ablation of the thyroid gland. You've removed the gland, you're now normalizing thyroid hormone, the levels are perfectly normal, and guess what? The problem persists. This is interesting. I-131 therapy may double the TSH receptor autoantibody level. Well, isn't that fascinating? It could actually make the disease worse. An abnormally high plasma level of thyroid hormone is associated with heart arrhythmias and osteoporosis when it occurs in the context of Graves' hyperthyroidism, but not with thyroid cancer that's been treated with high-dose thyroid. I hope you get it. I hope you got it. Exogenous thyroid hormone used in the treatment of illnesses, even when resulting in high circulating levels and suppression of TSH, does not show a correlation with the sequelae of the disease of hyperthyroidism and Graves' disease. Historically, when and how high-dose exogenous thyroid replacement was conflated with Graves' hyperthyroidism is unclear, but that's just the way the human brain works. You assume, you extrapolate. An observation does not prove causation, but you ignore that, unfortunately. Failure to adhere to the strict definition of thyroid toxicity and hyperthyroidism may have played a role in this process. Even today, high-dose replacement therapy is routinely referred to as hyperthyroidism. It's not. This belief that high circulating thyroid hormone is equivalent to hyperthyroidism has continued despite the robust body of evidence reviewed in this paper that contradicts that assumption. You know it, you understand it now, but understand that your peers don't, and don't even try to go there. When a patient says, my doctor says, when the doctor says no, then no. But then I don't feel as well, and now my cholesterol's up, now I'm gaining weight, now I feel terrible. Yes, I know. Well, what should I do? Go ask your doctor. There is more than sufficient evidence to conclude that high-dose replacement is not a risk factor for decreased bone mineral density among men, premenopausal women, and in postmenopausal women that take calcium. Problem solved. No quality studies have shown that high-dose replacement increases mortality or cardiovascular risk. Period. Contrasting the health risk of actual Graves' hyperthyroidism with the absence of evidence that high-dose replacement causes major health problems, there is sufficient reason to conclude that high circulating levels of thyroid hormone, whether it be due to Graves or exogenous replacement, are not the cause of the medical sequelae of Graves' disease. The most viable alternative explanation is it's the sequelae of hyperthyroidism that's related to an autoimmune process and the autoimmune antibodies that destroy and attack tissue. It is essential that careful differentiation between hyperthyroidism and Graves' disease and high levels of circulating thyroid hormone from replacement be maintained in order to promote clear communication, accurate diagnostic assessment, and optimal treatment planning. I want you to know it, I want you to understand it, but I also want you to know that nobody else knows it and nobody else will understand it, particularly your peers, particularly endocrinologists, and particularly the endocrine societies. I'm going to stop there and do this next article for the next webinar. As you can see, I'm out of time. I will now entertain questions.
Any of you that just joined us, please note in the lower right-hand corner of your screen, you should see the question and answer box where you can enter your questions to Neil. Back to you, Neil.
Dr. Torek asked, sometimes if I have pushed the TSH too low, patients will complain of palpitations that resolve when the dose is lowered. Yeah, that's true. This isn't thyroid toxicity. Well, yeah, it is. It's not. I wouldn't say it's thyroid toxicity. I would say it's symptoms of increased sensitivity to the hormone. Let me give you an analogy. When I prescribe estrogen to 99% of women, they do just fine on the dose that I prescribe. 1 to 5% will not. They'll get breast tenderness. Is that because they're estrogen toxic? No. It's because they have an increased sensitivity to the estrogen. What I do is I lower the estrogen for a month or two, and then I gradually go back up and increase it. And then after a month or two, the patient's able to tolerate that original dose. It's just that they didn't tolerate it initially. I find the same thing with thyroid. I always start low and go up slow. If you use too much too fast, they'll have a sensitivity to it. But oddly enough, I've had 2 patients that were very sensitive to thyroid, started them both on 1 grain, and they both had palpitations and tachycardia as a result. Oddly enough, both of these patients were psychiatrists. So anyway, we went back down to 1 grain and we tiptoed up. Now both of them do just fine on 2 grains. But initially they were very sensitive to it. So I think it's more of a sensitivity to it than it is a thyroid toxicity. So don't equate the sensitivity to thyroid toxicity, but yes, your point is well taken. And I can't remember, it's been a long time since I've seen someone that I started out on thyroid actually have side effects from it. Because I use a low dose, and I start low and I go up very slowly. Dr. Milkus, Steve asked, where does the package warning of osteoporosis risk from levothyroxine come from? Well, it comes from all the studies that I showed you. And that's, again, those patients are contaminated with Graves' disease, or those women that were osteoporotic, that were women in menopause that got thyroid, they still continued to lose bone. But when you go back and look at those studies, there was not a control group. And those other studies that did show loss of bone, and they gave them calcium, and they went back and looked at it, those that got calcium did not lose the bone. It was really not the thyroid that was causing it. It was the loss of calcium and the estrogen loss, because it was easily corrected with calcium. It was not corrected by eliminating the thyroid. It was corrected by giving them the calcium, which shows that the problem is the calcium in the hormone, not the thyroid hormone that's the problem. Otherwise, the bone loss that they measured on NTX and CTX would have persisted in spite of the fact that they gave them calcium. But when they gave them calcium, the NTX and CTX numbers normalized, showing that it was really the calcium and not the thyroid hormone. Robert asks, please repeat what you prescribe for any of your patients on thyroid hormone. I'm not sure what you mean. What I prescribe? Well, I use desiccated thyroid. The 3-hour lecture in part 1 describes how, when, where, how to monitor, adjust, and prescribe it. I can't do that on this lecture, sorry. What about the studies on toxic nodular goiter? I'm not sure what the question is. Toxic nodular goiter has high levels of thyroid, and I think what you're saying is, but those patients that have high levels of thyroid hormone from the goiter have the problem. Well, we don't really know what causes the nodular goiter. Is it autoimmune? Is there some other antibody? I don't know. When you remove the nodular goiter, then treatment is fixed. However, in many patients that don't have the toxic nodular goiter, but just have goiters or have nodules, you suppress their TSH to 0 with giving them thyroid hormone, and their symptoms and problems resolve. So again, I'm not so sure that it's the thyroid hormone as opposed to some other element that we're treating. Sean asks, are there any issues with high-dose replacement in Hashimoto's? No, the most common cause of hypothyroidism is Hashimoto's, and I use optimal replacement. I don't use high-dose replacement. High-dose replacement is what was used in those studies. That's up to 100 to 150 micrograms of T3. I don't use doses that high. I've used 100 micrograms to treat patients with severe fibromyalgia and severe fatigue with excellent results. But the majority of patients that I treat, I optimize, and I don't use high-dose replacement as used in the studies. I use optimal replacement. There's the difference. Dr. Lee asks, how do you treat autoimmunity for thyroid? You don't. You have to get into the bone marrow. I don't know how to treat any autoimmune disorder other than immune suppression with drugs and steroids. So I don't, for the Graves autoimmune disease, well, then you have to remove the thyroid gland. And unfortunately, again, the anti-TSH antibodies still persist. Kayla says, I have some patients who swear they got more anxiety when thyroid is increased. Yep, that's because they're thyroid sensitive. Then lower the dose. The free T3 isn't very high either. That's because they're sensitive to the thyroid. You have to go up very, very slowly in those individuals that remain sensitive. Again, they're not thyroid toxic, they're thyroid sensitive. Patients that take DHEA, they break out, they're extremely sensitive. Patients that are on estrogen, they're extremely sensitive. Some people have the same problem with testosterone. On the other hand, many people are very resistant to it. So there's some patients that need high dose replacement, and some people they just need very, very, very low doses. And if you raise it up very high because they're so sensitive, then they have side effects. Well, then you dose it based on your sensitivity. Patricia asked, a 52-year-old male showed his TSH is 5.9. Free T4 0.99. Not too bad. Free T3 is 3.7. Not bad, pretty good. He didn't want to go on thyroid replacement. I think that's fine. Yeah, that's okay. You don't have to treat everyone with thyroid. It's fine. He probably has a central deficiency as opposed to a primary disorder. You can have a secondary high and low TSH that's not related to the thyroid hormone. And he probably has a central then hypothyroidism because he's still producing plenty of it and his levels are fine and he's not symptomatic. Subsequent TSH of 10, it continues to go up even though his thyroid hormone levels are perfectly normal. He was put on T3 and T4 up to 2 grains, and when he takes it, he literally passes out after 3 hours. Well, don't give it. It's fine. Don't give thyroid. This guy doesn't need thyroid. Problem solved. So it's a central hypothyroidism, but his levels are still adequate. He still produces enough thyroid hormone, so he doesn't need it. Dr. Lee asks, is Hashimoto's autoimmune too? Yes, it is. In Hashimoto's, you produce antibodies that destroy the gland. In Graves' disease, you produce antibodies that stimulate the gland. They're just the opposite. Solomon asked, as a neuropsychiatrist, I use thyroid replacement therapy with resistant bipolar patients with excellent results. Yes, we've had a multitude of psychiatrists take the courses that have all described their tremendous success with optimizing T3 in these patients. It is so sad to have seen 3 patients relapsed with the bipolar symptoms when the endocrinologist takes them off the thyroid medication or change them from bioidentical thyroid hormone replacement to T4. Well, Solomon, you and I know that the literature shows that the T4 does not work for bipolar disorder. It's only T3, and it's high-dose T3. But please understand that your peers will not understand. But somehow or another, you think that the endocrinologist trumps you. You think that the endocrinologist is the specialist takes precedent over you. They know more. They have more experienced. Whatever they say goes. And the patient will then listen to the endocrinologist. Well, sorry, they don't trump you. You're the specialist. You can trump them. You know more than they do. You have more experience with it. Now you have this literature that I just presented to you. But understand that the endocrinologists don't understand this literature. They don't know that. You can ask any endocrinologist except Dr. Kadambi and a few other endocrinologists that understand it. Fortunately, there are some that high dose is not going to cause any harm. And for those endocrinologists that see high dose replacement by the psychiatrist, they understand that it's needed. And then when you take them off of it, the patient's going to crash and burn. Please do not feel that you need to succumb to the endocrinologist and you need to adequately explain to the patient. The endocrinologist is trained a certain way, you're trained a certain way. Your knowledge, experience trumps that of the endocrinologist. Don't be belittled by it. Solomon also asked, why do the endocrinologists still resist to test for free T3 and only use TSH and total T3? It's because of the way we were raised, what we were taught by the endocrine societies. I mean, that's how we were taught and raised. I was taught and trained the same identical way because somebody else trained them, somebody else trained them, somebody else trained them, and why don't they switch? Why is it that AACE still continues to use T4 only and denigrate the use of desiccated or T3? It all comes from Knoll Pharmaceuticals. It comes from those people that are in the endocrine societies that are heavily paid and financed by Knoll Pharmaceuticals to keep the guidelines as they are. And they've come out with multitudes of studies showing that the T4 works and T3 doesn't work. Yes, but those are all studies published by the pharmaceutical companies that had a economic, financial, political bias to prove that. Whereas if there's not a bias and you use T4 and T3 in an adequate amount, all the studies show benefit. If you use a small dose, it doesn't. Yeah, well, why did they do the studies? They did the studies because of a political and economic agenda. And that's why. Don't use free T3. It's a lousy test. And the reason it's a lousy test is because it doesn't come up when you use T3. It stays low. Well, of course it doesn't come up because I wouldn't expect it to. When you use T3, you suppress TSH, which suppresses T4. And the T4 levels will then fall. That's why you don't want to use T3, because the T4 levels fall and it suppresses the TSH. And they just simply don't understand it or grasp it because they don't have experience with it. Next question, Lolly asked, what is going on with Thyroid? Any insight on the shortage? It's a multifactorial as to the shortage. Knoll Pharmaceuticals bought, of course, Knoll Pharmaceuticals didn't buy it. It was Allergan that bought Armor Thyroid and quintupled the price overnight. And unfortunately, the main manufacturing plant in China was also purchased. That's why there's an increase in price, and that's why everyone was hoarding it, because we saw this. So it has to do with the hoarding of it and the availability of it. I am told, Armor Thyroid is very much available. It just costs 5 times as much. But the other Thyroid, from what I understand from them, in December, their manufacturing is supposed to be back online, and supplies should be back up again, hopefully. Kayla says, I have 3 anorectic patients, runner's triad, yeah. What is unfortunate, my sister, of course, their doctors are blaming thyroid for their weight loss. Don't use thyroid. I'm blaming it for their fertility issues and bone loss. Yeah, of course, I understand that. Now you understand why they will say that. All their doctors want them to get off the thyroid. Well, then take them off the thyroid. I don't fight, I don't argue. Then take them off of it. Is it true that low thyroid can affect fertility? Absolutely. Certainly it does. And, if you've taken the courses, you've seen what the effect of thyroid is on fertility and helping to improve fertility, particularly with patients with PCOS. But it also will affect fertility in any individual. But don't fight it. If the patients push back, then stop the thyroid. It's quite simple. You have to understand that what you know and understand, your peers will not know and understand. And you understand, and you have to respect why they are the way they are, why they're taught the way they're taught, and why they believe the way they believe, because you and I were both taught the same identical way. So have patience and respect for your peers. Father, they do not know what they are doing. Saul asks again, is it better to use a bioidentical porcine thyroid medication without fillers and binders compared with Armor? Yes, my choice is to use a compounded desiccated thyroid that doesn't have the binders and the fillers in it. And in my personal experience, using the compounded works better in achieving levels that are much better. I don't know why it is. I just observe it. I measure levels of myself and my patients and my staff on Armor and other hormones, and then test them again on the desiccated that's compounded. I will always get a better level with the desiccated. I don't know why. I'm just giving you an observation. So yes, that's my choice. Maura Crouch asked, I joined today's webinar late, but what is the definition of high-dose thyroid? I don't know. There was not a definition that was given. It's just what they used in the studies, and that could be anywhere from 25 to 50 to 75 to 100 to up to 150 micrograms of T3. I do not remember you using this term in the conferences. I didn't use the term in the conference because I didn't want to confuse people. That's why I can't fit everything into the lectures in the conferences, and as a result, I have to do these lectures to sort of explain the differences, because if I try to explain the difference in the conference, then I can't get through the lectures. Dr. Connell asked, ever see hypothyroid lab and clinical convert to fulminant hyperthyroidism? Oh yeah, absolutely. After starting thyroid, no, not rapidly, no. I think it's coincidental, but 1 out of 100, 1 out of 2, 3, 4 out of 100 of patients that you treat with thyroid will eventually go on to develop Graves' disease. It's an autoimmune disorder. Giving thyroid does not cause the autoimmune disorder. But yeah, you will see those patients, and that's why you probably want to monitor your levels. It's sort of a slow onset. What I've seen is that the TSH levels will become a little bit more suppressed, but you'll start to see the T4 levels go up. Normally with desiccated thyroid, the T4 levels will be low. And what you'll start to see is an increase in T4 levels with more suppression of TSH, in spite of the fact that you didn't change your thyroid dose. So that's an early indication of Graves' disease development. And it's not due to taking thyroid. It's an autoimmune disorder that has nothing to do with taking thyroid. It's just what God made. How common is it having both Hashimoto's and Graves'? I don't know. I don't know how to answer the question. Sorry. Is there a true, definitive, sensitive test for Graves'? Yeah, you can measure TSH antibodies in addition to having a suppressed TSH and high T4 and high T3. So I'll ask, is it better to use ionic minerals and only 1,000 milligram of calcium? Yes, I'm not a big fan of giving calcium. I use calcium and magnesium frequently, but not calcium by itself. The problem is really not the calcium. The problem is the hormone that drives the calcium into the bone is deficient. Saggy asks, you've been asked by patients if I take hormone to optimize my T3 and T4 level, then the TSH will be suppressed. Yes, that's true. Not in everyone. You can get optimal T4 and T3 levels without suppressing the TSH, and some people will have suppressed TSH. But that doesn't mean they have hyperthyroidism if you suppress the TSH. Hyperthyroidism is from thyroid hormone. Sensitivity and side effects are due to thyroid hormone, not TSH. But what we were taught and misled to believe, it's the TSH. And that's why you don't want to suppress the TSH, because everyone thinks and knows and understands that when you do, it's going to cause the harm. And yes, when you do suppress the TSH, you will shut off production of hormones by the gland. If you don't want to suppress production of hormones by the gland, then don't suppress the TSH. Yes, but then your free T3 levels are low. Yeah, I know. Well, what do I do then? I don't have an answer for you. Then give T3 and optimize it. That's why we do it. Next question, since the TSH is low, it won't stimulate the thyroid gland anymore. Will I be dependent on the medication forever? No. There's millions of patients out there with suppressed TSH that are on thyroid hormone. And when they run out of their thyroid hormone, their TSH comes back to what it was before within probably a week. So no, you won't permanently suppress it. You'll suppress it maybe for 5 or 7 days, and then it comes back to what it was before. Next question, how to use reverse T3? I don't know. You can use it any way you want. I don't test for reverse T3. I do not find that it's valuable. It's just an expensive test to do, and it doesn't help me optimize T3. Well, pundits will then say, well, yeah, well, you need to know what it is, because that way you can treat it. I don't know how to treat that. The only way I treat it is with optimizing the T3. But you can use it, and people say, no, you have to use it. And I say, yes, go ahead and use it, but I can't tell you how to use it. What if it's low? I give T3. What if it's high? I give T3. What if it's in the middle? I give T3. Any difference between immediate release and sustained release? Yes. I don't use sustained release. I know in the Wilson's protocol you do. I used to use that. I used to do it. Some people do just fine in the sustained release. Some people don't absorb it. Using the sustained release T3 is like taking your thyroid with calcium and iron. It'll suppress absorption of it. So some people don't do very well, and some patients that get the sustained release T3, they will not absorb the T3. The T3 levels fall dramatically when you use an SR. I never use SR. You can, but don't call me and ask me why the T3 levels are so very low. Dr. Laura asked, you've had a few patients complain of feeling worse, increase in brain fog after starting thyroid. Those are patients that don't need thyroid. Is it likely that I've underdosed them and they simply need their dose increased? No. If you eat tomatoes and break out, don't eat tomatoes. But what about just a little tiny bit? A little tiny bit of tomato will make you break out. Then don't use it. If they don't tolerate it, don't use it. I don't have any other answer other than don't use it. Yeah, it could be a sensitivity issue. Then you can go back and go up slower. I do that. If patients take it and they feel jittery, then I cut the dose in half, or take it every other day, every third day for a month or two, and then go back up slowly. Almost in all circumstances, the patient will develop tolerance to it and will be able to tolerate it. It's a sensitivity issue, not a toxicity issue. Next question, have you ever had a patient try to see you over your treatments? And if so, do the studies you cite help your defense? I've never had anyone sue me, knock on wood. But yeah, that's why I provide the studies. If you're worried about it and you're concerned about it, please do not prescribe thyroid. But understand that the thyroid is extremely important for a multitude of reasons that I go through in parts 1, 2, 3, and 4. If you're uncomfortable, don't do it. Please don't do it. Refer to somebody that's comfortable with it and that knows how to do it. That's the best advice I can give you. If you're worried about that sort of thing, do not prescribe thyroid. Please don't do it. Please refer them to someone else that knows what they're doing and is confident and comfortable with doing it. Guidance and timing of the lab draw, 5 hours. Sean says, do I stop checking thyroid levels at a certain point when you're treating symptomatically? Yes, I do. When the level is optimal, then I don't test any further. You can retest, like I said, on a yearly basis to watch the TSH becoming more suppressed and the T4 going up, meaning they have Graves' disease. But, patients that are developing Graves' disease will probably have, signs and symptoms of excess. And if a patient has signs or symptoms of excess, test the levels and reduce the dose, or watch for a simultaneous development of Graves' disease. Dr. Harris asked, do I test for reverse T3? You can. You can absolutely test for reverse T3. Sharon asked, a person on 0.75 micrograms of T4 was converted to 1 grain of compounded thyroid. That's not enough. She felt bad, and I increased her to 1.5 grains. How do you typically convert? It's apples and oranges, but typically it's 1 to 0.1. So if they're on 0.1, you start with 1, and then you titrate up accordingly by symptoms as well as levels and symptoms. Hi, Heshi. When you use 100 micrograms of T3 for fibromyalgia, how much T4 do I give? I know it's been a while since you attended part 2. I don't use just T3. I optimize T4 and T3 with desiccated. Once you're optimal, then I will add T3 onto it. So I don't use T4 by itself. I will optimize with desiccated first and then add onto that T3 in order to treat symptomatic fibromyalgia. Grace says, when I give Armour Thyroid, typically the TSH level falls to a good level. Yes, that's what happens. Free T3 is optimized, but the free T4 also falls. Yes. Can you just add T4? I don't, but you can. The reason it falls is because you're shutting off production by the gland. When you give T4 and you suppress the TSH, you shut off the gland's production of T3, which is why so many people that take T4 don't feel better or feel worse. If you give just T3, you'll shut down the TSH, you'll stop stimulation of the gland, and you'll shut down production of T4. That's why you should not give just T4 alone, and you should not give just T3 alone. You give both T4 and T3 to compensate for the shutting down of T4 or T3 produced by the gland that you're shutting down. So that's why. If you give T4, the T3 will fall. If you give T3, the T4 will fall. That's expected. Dr. Thatch, how are you, sweetheart? Do you find hypothyroid patients that have been on long-term suboptimal T4 therapy more difficult to manage? Not really. I don't really think that being on T4 affects management any more than not being on the T4. They both need to be optimized. And as you know, receptor site sensitivity plays a major role in this. So getting your levels up to optimal helps the majority of people, but there's a minority of patients that don't improve due to receptor site resistance, loss of signal transduction inside the cell, a multitude of other factors that will affect symptoms and improvement in spite of the fact that your levels are perfectly normal in the serum. So no, I don't have any trouble. I think most people have trouble because they are not comfortable or don't have the experience with optimizing these patients by giving more. So yeah, I know the labs and symptoms are all over the place. And the more you play the piano, the more seat time you have playing the piano, the better you get at playing the piano. The more seat time you have in treating these patients, the better you get at it. And they will be all over the place. And sometimes it's a handful to try to manage them. But start slow, go slow, and increase and optimize. And I find that most people are not optimal. And when you get optimal, that's when you'll see the patients improve. But what I see for most patients that are sent to me or that come to me, they're just suboptimally treated because everyone's uncomfortable with doing so, and the patient then suffers. And then, the doctors just aren't comfortable with doing it. I understand that. Then refer to somebody that is. I think, Ursula, you just need to go up a little bit more, go slow, and use a BID dose. Sagi asked, do I ever use a BID dose? Yes, all the time. What dose do you divide the dose? Whenever they have symptoms of excess by taking just it once a day. Would the night dose cause insomnia? It could. I typically don't see that, but theoretically it could. But remember, most endocrinologists prescribe T4 at bedtime, and they don't see insomnia with that. It's not coffee. It does stimulate metabolism, but it doesn't necessarily have a caffeine, I'm wide awake, I can't sleep effect. It's more of a metabolic effect. So, Dr. Lang, are you freezing your gonads off up there in Montana? Sunny and warm down here. Anyway, I hope you're having a good winter. A lot better than everyone else down here because the ski resorts are really lacking snow. Dr. Lang asked, is it the T4 or the T3 that suppresses the TSH, or both? Both of them do. Just depends on how much that you use, but both hormones can have negative feedback inhibition to the hypothalamus, which will suppress the production of TRH, which will then suppress production of TSH, and so on and so forth. Stephen asked, do you treat your patients who do convert to Graves from hypothyroidism? No, I refer to a endocrinologist, although many patients now come to me and say, I don't want I-131, I don't want surgery, so I will treat with, if a pregnant, propylthiouracil, or if not, then methimazole. Very often, the Graves' disease, after being treated with thyroid suppression for 6 to 12 months, will burn out, and the thyroid function will go back down to normal. And then you've saved them the hassle and headache of going through that therapy and being on a lifelong T4. Not that that's bad, but the problem is that most of these patients that get their thyroid gland ablated will lose all their T3, and then they gain weight and they feel worse, and no one understands why. So no, I don't have a specific protocol. It's just like insulin. How do you prescribe insulin? You titrate to effect. How do you dose the methimazole? You titrate to effect, and you observe and watch the numbers, and then when the numbers start to improve, then you can taper off. The endocrinologist hasn't communicated with me. Sorry. Using methimazole, steroid, and Inderol or any other beta blocker. I will use a beta blocker to control the symptoms initially because it'll take the methimazole, a week to sort of knock down the production of the thyroid hormone, and then you can sort of back off on the beta blocker. Mark asked, when I use compounded desiccated, do I use the same ratio of T4 to T3 as the commercial available preparations? Yes. I do, and I went through that in part 1 using the same identical concentration. Do I ever give additional T4 to patients whose brain fog does not improve on the typical ratio of T4? You can, yes, you can. Stefan asked, with the short half-life of T3, do I ever prescribe Armor BID? Yes, absolutely, I do. If so, are you doubling the dose or splitting it? I give it usually once a day to most patients because they don't need it twice a day. Once a day usually works just fine. For those patients that have metabolic issues, PCOS patients, chronic fatigue, fibromyalgia, then I will split the dose. And I went through that in the treatment for chronic fatigue, chronic fibromyalgia section of part 2. Okay, it's 12:40. That's an hour and 40 minutes of constant rattling on my end. I hope this was fun, educational, informative, gives you better confidence, knowledge, and experience with prescribing thyroid and understanding why your peers think and feel the way they do, why they fear what you do, why they don't like it, and why they will be thoroughly against what you do. Again, I caution you, fly under the radar. If you have patients that have other doctors and the patient's going to tell other doctors, explain to other doctors what you're doing, I will not treat those patients. I can't explain to the patients and to the other doctors, and the other doctors truly understand and think that what you're doing is absolutely incorrect. Understand that. And as a result, you're not going to be able to treat so many patients because they will interact with other doctors, and the other doctors will not understand, will interfere with your treatment. I hope that's fun. Chris, Mary, Dana, thank you very much. Good day to everyone. Thank you. See you next month for the next webinar.
Thank you, Dr. Rozier. I hope our listeners enjoyed it as much as I did. Our next webinar will be on February 7th, part 2 of thyroid replacement. Thank you again, Dr. Rozier, and everyone who joined us today. Have a wonderful rest of your day.